Hello, I'm Barbara Levin, the Executive Director of Neurofibromatosis Mid-Atlantic. Welcome to Managing Pain in Neurofibromatosis, presented today by Dr. Andrew Tyler Putnam of the Section of Palliative Medicine, Smilow Cancer Hospital at Yale-New Haven Cancer Center in New Haven, Connecticut. I want to thank you so much for joining us for this very exciting and informative program. We are joined today by people from throughout the world. We're very happy to be sponsoring this educational event. Because we have some folks today joining us who are hearing impaired, I've written down my opening remarks. We will provide a closed caption version as soon as possible. NF Mid-Atlantic is a nonprofit organization based in Baltimore. We've been around for 34 years, and we remain committed to our founding principles of supporting people with NF, their families, their caregivers, their circles, and anyone who has an interest in NF by providing awareness, support, and education. A few housekeeping items. There's a question pane on the right side of your screen. If you have questions during the presentation, simply type in your question and click send. At the end of the presentation, we will do a Q&A session and take as many questions as time permits. I will be muting everyone while Dr. Putnam speaks, but feel free to write your questions. This broadcast is being recorded and will be available on the NF Mid-Atlantic website at www.nfmidatlantic.org by February 28, 2013. It will also be available at our YouTube channel, Great Gabby Dog. You can view all our archived videos at our website and YouTube channel. To be informed of release, please subscribe to our channel, follow us on Facebook, or on our Twitter stream at NF Mid-Atlantic. We are so honored to welcome Andrew Tyler Putnam, MD. He is an assistant professor specializing in pain and palliative care at Smilow Cancer Hospital at Yale-New Haven Yale Cancer Center. Dr. Putnam has significant experience in palliative therapy and end-of-life decision-making and care. Many people at NF Mid-Atlantic know Dr. Putnam from his 11 years of practice at the Palliative Care Group at Lombardi Cancer Institute at Georgetown University Medical Center in Washington, D.C. Dr. Putnam is a past recipient of NF Mid-Atlantic's Make a Difference Award, which he received after glowing recommendations and unanimous approval of the NF Mid-Atlantic Board of Directors. Dr. Putnam has been a generous friend of NF Mid-Atlantic and an invaluable resource. We are so appreciative of his devotion to us. Before we start, I'd like to remind everyone that NF Mid-Atlantic survives solely on your donations. If you appreciate these educational webinars and you want them to remain free, please consider a donation in any amount. You may do so at www.nfmidatlantic.org. We're a tax-exempt 501c3 nonprofit organization, and we've made donating very easy. Please indulge us one moment while I turn this webinar over to Dr. Andrew Putnam. Thank you again.
How are we doing? Are we good?
Yes, we are all set. Dr. Putnam, if you would like to present your slides.
Thank you very much. Thank you, Barbara. Made me sound quite wonderful. I wish I could tell my wife all of that stuff. But anyway, thank you all of you who are listening right now. I appreciate your coming today and spending this time. I thank Barbara for introducing me to this because I could be sitting here in my pajamas right now doing my webinar and nobody would know. And one other thank you, I'd like to thank very much Diane Baldwin and her son Brett, both of whom have taught me everything I know about neurofibromatosis. So thank you, Diane and Brett. I'd like to talk today about pain, and let's see here. How do we do this? It suddenly does not want to go forward.
I have that trouble sometimes, Dr. Putnam, and if you right-click, you can Good. You did fine.
Yeah, okay, I think we're, let's see. Okay, good. So objectives, I want to talk, most of what I want to do is give an overview of pain today. I'll talk some about pain management, both with opioids, and talk about some other pain medicines. There is a lot now about alternative ways of controlling pain, acupuncture, etc. I am not an expert on those. There are definitely types of pain where those are helpful, but I am not going to talk about them just because I don't know enough about them to really give you a good presentation. So be opioids and other pain medicines, and then I'd also like to put in a couple slides at the end about constipation, because the opioids cause it in many, many people, and it's something that doctors often don't want to talk about or just don't feel comfortable talking about. First, however, I'd like to give one slide on palliative care. Palliative care is often misrepresented or misunderstood to be hospice. And as a palliative care doctor, I would say that about 20% of the patients that I see are hospice patients. And about 80% of the people I see are actively getting treated for whatever they have. And so just quickly, palliative care, specialized medical care for people with serious illnesses. This type of care is focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. So we work with families too. It's provided by a team of doctors, nurses, chaplains, social workers, musicians, pharmacists, all sorts of other people. And we work with the patient's other doctors, so we don't usually take over. We work with them to provide an extra layer of support. Palliative care is appropriate at any age and at any stage in a serious illness, even right at diagnosis, and can be provided together with curative treatment. The joke among palliative care doctors is that when we go into the hospital, we should carry a scythe and wear a black hood, as we remind many people of the Grim Reaper. But as it shows here, it can be any stage of the disease. Okay, on to pain. Pain doesn't really get a whole lot of respect in the medical community, or even in society. You say, a little pain never hurt anyone, or what doesn't kill you makes you strong. The problem is that someone who has a lot of pain, it really affects their quality of life. Physically, it can disturb their sleep, can lead to decreased strength and endurance. I have one patient who has pain and she's not able to pick up her 3-year-old daughter. It's very sad. Pain can lead to nausea and diminished appetite, which makes it hard to fight whatever illness one has. Psychosocially, it can certainly lead to depression and anxiety, and I'll talk about those in a minute. Irritability, difficulty concentrating, and diminished social relationships. For people who have severe pain, often what they will do is they'll just stay home unless they have to leave their house for doctor's appointments, etc. So it really takes a person's life and makes it much smaller. What is pain? It's sensory input, so I hit my thumb with a hammer or I step on a nail, but it's modified. That sensory input is modified by memory and emotions. Anxiety and depression can take that pain and make it much worse. The experience of the pain is much worse. And I'm not saying that it's all in somebody's head, but what is in the head can make the pain a much worse experience. So as a doctor, if my patient is very anxious or is depressed, I need to treat those as well as the pain. There are no objective biological markers for pain. There's no test to show it at this point in 2013. So the most accurate assessment of pain is what the patient says. A quick bit on the pathophysiology, and the main reason for this is it affects how pain should be treated, and a lot of doctors don't understand this yet. Nociceptive pain is what most of us think of for pain. Active nociceptors, and these are pain receptors. These are the nerves in the hand that if you hit your thumb with a hammer, bottom of your foot, if you step on a rock, so that receives the pain, and then healthy nerves transmit those signals over to the brain and say, ouch. And so this is protective, because if you step on a nail, if you feel it, you stop and you take the nail out. It doesn't stay in the bottom of the foot and fester. There are people who especially diabetics, are very common, that they lose feeling in the bottom of their foot, and then something that would have caused pain when they were younger, they don't feel that pain now, and they can end up with big open sores on the bottom of their foot. So nociceptive pain is protective of the body. That comes in two different types, and just somatic is usually bones, joints, skin. Cellulitis is an infection of the skin, and typically it's well localized. People can point with one finger. If you've seen anyone with a broken rib, they can take one finger and say it hurts right here. As opposed to visceral pain, which is another type of nociceptive pain, but this is in usually the abdominal or the chest, inside the body content. So an appendicitis at the beginning, peptic ulcer disease, a heart attack. Often it's poorly localized. We can feel it sort of all over the place. In the belly, if it's appendicitis at the beginning, the whole thing hurts a little bit. And it comes from either squeezing or stretching of the internal organs. Patients may describe it, or it feels like deep squeezing or aching or pressure, and they may get some nausea or vomiting along with that type of pain. There. The other main type of pain is called neuropathic pain. Neuro stands for nerve, and pathic is like pathology. It means something's actually wrong with the nerve. And this is not protective. This is caused by an injury to the peripheral or the central nervous system. The central nervous system is the brain and the spinal cord down the back, and then the nerves that come out of that are the peripheral nervous system. So the problem can be in different places. Could be post-surgical pain. Just, anytime a surgeon cuts into a body, they're going to cut very small nerves. There's no way around it. And usually those do fine, but some of those may feel funny or hurt for the rest of the person's life. Shingles can be very painful, diabetic neuropathy, or phantom limb pain. So there, the arm is cut off or the leg is cut off, but the person feels the pain in the hand or the foot, for example, that isn't there. And that's, again, caused by an injury to the nervous system that leads someone to have pain in a part of their body that's no longer there. So as I said, this is not protective the way nociceptive pain is. Often there are two types. That can be what's called lancinating pain, which is sharp, shooting. It may feel like an electric shock that comes for 2, 3, 4 seconds and then goes away. And so we think it's spontaneous firing of nerves, sort of like a seizure. And so we often use anti-seizure medicines to block these types of this type of pain. Because if you think about it, if the pain only lasts 3, 4, 5 seconds, but it's pain that can wake someone up from sleep. It's pain that can stop someone dead in their tracks, so it can be very severe. But by the time they reach for their pain medicine, the pain's gone. So the only way really to treat this type of pain is to try and prevent it. The other common type is constant pain, and that's burning. Diabetic neuropathy is one example of this, but there's lots of others. And these may respond better to different types of a type of antidepressants, and again, I'll talk about that shortly. The assessment of pain. These are questions that, if you have pain and you're going to a doctor or a nurse or someone to talk about the pain, these are questions that you should think about before you go and see the person to be able to give them a good explanation of what you're feeling. Many doctors forget to ask these types of questions, but it can be very helpful for someone who's treating pain. These are questions that I would often ask. So the location, where does it hurt? Is it superficial? Is it near the skin? Is it near the top? Or is it very deep? Does it feel deep in the body? And I'll often press on someone's where the pain is and say, you know, am I able to touch the pain or is it just too deep? One thing to understand is that you can often have pain in more than one place, 2, 3, 4 different places. And sometimes doctors will ask about, you know, where's your pain? Oh, it's here, here, here. It's here, and they'll ask you about that, but they'll forget to ask if it's in other places too, and you need to bring that up. Is there a pattern of radiation? So if my pain hurts in my shoulder, does it go down the arm also, either continuously or for a very short time? Quality, what does the pain feel like? Is it dull? Is it sharp? Is it burning or tingling, like if your leg goes to sleep and it starts to wake up, you can get tingling. It could be the shooting pain or electric shock. And then one thing to think about is I have patients who come to me because they're very uncomfortable, and I ask about their pain, and they'll say, no, 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 it's discomfort, or I'm uncomfortable. And so it's important for the doctor to use the language of the person with the pain. But again, often we don't. And then numbness. Numbness isn't technically pain, but we treat it as such. If the nerves in a certain part of the body aren't feeling anymore, if I touch someone's leg and they don't feel me, or I touch the bottom of the foot and they don't feel me, again, that's a type of neuropathic pain because the nerves aren't working. And that's something that doctor needs to know about because it very much can affect your care and if you need to see somebody else as well. Temporal profile in time. When did the pain start? Has it been going continuously, or did it stop and then start again? Is it time of day? Someone who has pain in their spine may be fine while they're standing up, but if they lie down at night, that can make the pain much worse. Or relation to movement. Some types of pain, people can be sitting in the chair, lying in bed, perfectly comfortable, but when they start to move, that joint or that bone starts to move, or the muscle, and that's when the pain is. So it's important to think about those. Severity, which often drives patients crazy. People ask on a scale of 0 to 10, what's your pain? And the problem is that for a doctor or a nurse or a physician's assistant or any clinician, is you can tell me that you've got a headache, but I don't know, is this your worst headache, your better headache? How does this rate for you in pain? And the numbers usually takes a couple of questions to get that, because certainly I've had people who were crying when they told me their pain was 2 out of 10, and I have had people at 9 out of 10 who are sitting there looking okay. Don't worry so much about the numbers. Try, but there's really no exact way to explain it, but it's a way to try and get people to be able to help people explain their pain to someone else. And then it's always important to know what makes the pain better or what makes it worse. And could be worse with movement. Heat could make it better, or cold could make it better or worse. So those things can be very helpful to your doctor. Assessment also, establish a time course. When you're seeing someone and you're telling them about your pain, you may have constant pain, constant burning pain, or constant inflammation, and it's easy to tell the doctor about that, but sometimes pain is intermittent, and it's not going on right when we see someone, so it's important to think about that and remember. And sometimes both. What I was talking about with the nociceptive pain, the usual pain, and the neuropathic, some people have constant pain going all the time, but then they get what some people call zingers that shoot down the leg, shoot down the arm, or cross the chest, and often those are forgotten about. And as I said earlier, we treat those in different ways, ideally, and so it's important to tell people, tell the person treating you. The intermittent pain is three major types. Breakthrough pain, which many people often, the other two, they just call it breakthrough pain. That's when someone's usual pain increases episodically and unpredictably. So you don't know when it's going to get worse. You have discrete episodes. You may be sitting watching TV, or you may be walking, and suddenly the pain comes on, and it may last for a short time, seconds to minutes, or it may last for a much longer time, but you don't know when it's coming. As opposed to incident pain, and this is predictably caused by specific actions, either voluntary or involuntary. So voluntary, if you think of someone having big pain in the hip joint, person may be sitting and very comfortable, but can say, I know that if I stand up, my pain's going to get worse. If I walk, it's going to get much worse. But then if I sit down, it'll get a little better. And if I stay sitting or lying down, the pain will either go away or get much better. That's voluntary incident pain. And involuntary incident pain would be pain that comes when you cough. So it's usually not there, but we don't have complete control over when we cough. And so you cough, and that's when the pain comes. The easiest one, or should be the easiest one to treat, is end-of-dose failure. And that's if you're taking pain medicine every 4 hours, or if you're on long-acting pain medicine every 12 hours, before the next dose is due, the pain starts to get worse. And it gets to the point where if you're taking it every 12 hours, let's say at the end of 10 hours, the pain is worse and you really want to take another dose. And it's important to explain that to whoever's treating you, because that's the easiest one. You either change it to every 8 hours or you increase the dose in order to cover that 2-hour part. So if you gave a higher number of milligrams at the beginning, it's more likely to last the full amount of time. So that, with an adjustment to the medications, usually helps. Now, the real tough type of pain, or can be very tough type, is the incident pain, especially the voluntary ones. Because if it's a metastasis, if it's cancer, and I'm sorry, I work in a cancer hospital, and so most of the examples I have are cancer, but someone who has something really bad with that joint and they have no pain when they're sitting, or very little, if they get up and start to walk around and the pain goes from very little to very much, very fast, that is a big problem to control, because you need a lot of pain medicine very quickly, but if you give them a lot of pain medicine all the time, then when they stop moving around and the pain stops and the pain gets much less, the person is going to fall asleep because of all the pain medicine they have. So we often give people PCAs, that's a button, or PCA for patient-controlled analgesia, which is pain medicine, so they can give themselves an IV dose when they need it. It works faster than pills. Pills take 45 minutes to an hour to kick in. But often for severe incident pain, they need some sort of procedure. If it's cancer, they may need radiation or chemotherapy. If it's a fracture in the spine, of a bone in the spine, they may need vertebroplasty, which is putting cement into it, or they may need some sort of surgery. So incident pain can be very challenging to take care of. Opioids. There are two main problems that I think of when about managing severe pain, and I lecture about this a lot. One, as I said earlier, is that there's no test to demonstrate pain. It's not like you can test someone's blood sugar and, blood sugar's 287, that means diabetes. There isn't with pain. So the problem is that the physician can either prove it or disprove it. And as a doctor, I can tell you we don't like things we can't prove or disprove. The problem, as I lecture and I say this to lots of doctors and other clinicians, is that the patient can't prove it. And so sometimes what happens is you get a CAT scan and it doesn't show anything. And so people are sort of left wondering, do they really have pain? but the patient who really has pain has it, and it's very difficult to have that pain and also have to figure out how to convince someone that you have it. So I ask physicians to believe their patients, because they should. The other tough part about managing severe pain is the best drugs we have for most severe pains are opioids, morphine, Dilaudid, fentanyl, and they are drugs of abuse. I mean, people will lie, will steal to get these drugs. And they cause negative feelings for patients. Many patients don't want to take them because they worry that it makes them an addict, which it doesn't. More on that later. Clinicians don't like to prescribe them, and even pharmacies. Many of them don't carry them or don't tell people they carry them because if they're in a city, they worry that they might get robbed for them. Well, so what's so great about opioids? Well, most types of pain, they relieve, they make better. They either greatly improve it or take it away. There's no analgesic ceiling. And an analgesic ceiling means that if you give increasing doses of a pain medicine, that at some point it stops, you increase, it just gives more side effects but no more pain relief. With ibuprofen, which is the same thing as Motrin or Advil, those three are all the same, it's usually about 800 milligrams every 6 hours or 4 times a day. If you try and give more than that, and I'm not recommending those high doses because they can have problems, but beyond that, most people get no increase in pain relief. With Tylenol, it's not really an analgesic ceiling, but you go above a certain level and you're really worried about liver damage. With narcotics, you can go higher and higher as long as you go in appropriate increases. You know, you don't want to cause problems by going up too fast. And also, there's no risk of damage to other parts of the body. Like with liver, you worry with Tylenol about damaging the liver. Ibuprofen, Advil, Motrin, and others, aspirin, those you worry they can have cause kidney problems, and they can cause stomach ulcers. There's also no increased bleeding risk the way there is with Advil or Motrin. Those drugs get stopped a few days before surgery so that people won't bleed too much during surgery. Opioids tend to be effective. The most common reason it doesn't work is reluctance on the part of the clinician to increase the dose until pain is relieved. Okay, they should increase the dose until either the pain is relieved to a level that the patient finds acceptable, or there are unmanageable side effects that you can't deal with in a different way, in which case you might need to, you get to that point and the pain's not well treated, you may need to go to another narcotic pain medicine, but they should increase it because, as I said earlier, there's no absolute upper limit to appropriate doses. And the way to think about the not working, not increasing the dose, is if you take ibuprofen or acetaminophen, Tylenol for a headache, and 2 tablets works. If someone only gives you 1 tablet, then it may not work for you. However, it doesn't mean it's the wrong drug. It just means that you're getting the wrong amount. And so opioids usually can do the job. Now, WHO is the World Health Organization, and back in, 1990, I think, they developed a way to classify pain medicines. So for mild pain, ASA is aspirin, or acetaminophen, which is Tylenol. NSAIDs, non-steroidal anti-inflammatory drugs, those are Motrins, ibuprofens, Advils, naproxone. Those work for mild pain. Then I'm going to skip part 2 for a second. And then for severe pain, the third step are the heavy narcotics, morphine, hydromorphone, which is Dilaudid, methadone, fentanyl, oxycodone. Now, in the middle, for moderate pain, the A at the beginning stands for acetaminophen or Tylenol. So acetaminophen and codeine, or Tylenol with codeine in America, is called Tylenol number 3 or number 4. There are other names, but that's the most common here. Acetaminophen with hydrocodone is often called Vicodin. That's how it's best known. And acetaminophen with oxycodone is best known as Percocet. There are other names for these, but those are the most common ones, at least that I've run into. The danger of those drugs is, although they can help with pain, the danger, if you take too much, is that the acetaminophen can really affect your liver, can really hurt your liver and kill off parts of your liver. Now, in small doses, that's fine. But if someone's taking those and their pain starts to get worse and worse and they take more and more, they may end up wanting to take more than the doctor prescribed for them. And if you're one of those people using these types of drugs for your pain, I strongly suggest that you don't go higher than the doctor prescribed, because you can really do damage to yourself. Not from the oxycodone or the hydrocodone or the codeine, but from the acetaminophen. Tramadol is a newer opioid. It's sort of moderate, as it says here, and it's known as Ultram in the United States. This can help with some types of pain. It doesn't have the acetaminophen in it, but it does have a maximum dose. Notice that on all three steps are adjuvants. These are other medications that can help with pain. I'll talk about those shortly, but they can be used at any type. For example, if people have that lancinating electric shock type of pain, now you may be using narcotics, but you want to have something else to treat that specific pain. 6 main opioids for chronic pain. There are a couple other ones. One is, the most best known is probably morphine. It is quote-unquote natural. Morphine and codeine are the only two that come from the poppy plant. The rest are made in the lab. Morphine can come in pills, liquid, and it comes in long and short-acting forms. People tend to be afraid of morphine. When I start someone on a narcotic, often they'll say anything but morphine. What most people don't understand is, of these 6 opioids, morphine is the weakest. It does have the most side effects, but it's still very effective and a very good drug to use, and in most places, morphine is the first narcotic they will use. Oxycodone, the long-acting, is called OxyContin. Been in the news in America a lot over the last several years. Oxycodone is only oral, as opposed to morphine, which does have IV as well. And as I said earlier, Percocet is part oxycodone and part Tylenol, so be careful of the Tylenol. Hydromorphone, which is also known as Dilaudid. And again, for those of you listening in other countries, my apologies, because I'm sure there are different names there in these other countries, but I don't know what they are in different countries. But hydromorphone here, known as Dilaudid, also pills, liquid, IV, short and long-acting forms, and it does come as suppositories also, so you can use it rectally if people are nauseous or vomiting and still need it. Another opioid, another narcotic is fentanyl. Fentanyl gets bad press because it can be used to kill people. If certain people get a hold of it on purpose, but it's a great pain medicine. It comes in a patch that you wear on the skin and change every 3 days. It can be helpful. It's IV. And then there are forms for oral absorption, one that looks sort of like a lollipop, a couple that are like pills that you just put between your cheek and gum and they dissolve. These work faster than pills do, and so they can be helpful for people who can't swallow pills or for some reason have a blockage. It can also be absorbed through the nasal mucosa. The one that gets squirted up into the nose. And fentanyl is 100 times more potent than morphine, which sounds scary, but what happens is that we just adjust the dose and we give 100 times less fentanyl as morphine, so we give about the same amount of pain relief, just different amounts of the medicine. Methadone, which I could give a whole lecture on, is a wonderful pain medicine. It's very effective, oral or IV, but it's also tricky to use, and most people worry about it because it's used for recovering heroin addicts. However, is very effective for different types of pain, and it's more effective than the other narcotics for some types of pain. And then oxymorphone, also long and short acting, and also oral only. These are the most common pure opioids that are used. There are a few others like codeine or levorphanol that don't get used as often. Codeine probably should not be used. It doesn't work because of genetic reasons in probably 7-8% of people, and it's best to avoid it. So when increasing doses of opioids, we need to increase them by certain percentages. So if someone is getting 30 milligrams of morphine at a time, if they increase it, if it's not working and they go up to 33, they go up by 10% to 33 milligrams, that's likely not to be felt as a difference by the patient. For moderate pain, you usually need to go up by 25 or 50%, and severe pain, but you increase by half or possibly even need to double the dose. It depends on the pain, depends on how the patient's feeling, and again, this is not something that you do on your own at home. This is something that you do with a medical clinician giving you advice. These drugs are very helpful for pain, but they can be dangerous. And so please, when you're adjusting these, get help from a clinician. Don't just do it yourself because your pain's worse. Long-acting opioids, which are fentanyl patch or MS-Contin or OxyContin, they're the same drug as the short-acting. So MS-Contin is morphine, but it's in a timed-release form. Same with OxyContin and oxycodone. In these cases, if someone has constant pain, the goal is to prevent as much of the pain as possible by getting a stable level in the body of the pain medicine. Even with the perfect level of long-acting pain medicine, breakthrough medicine, you may not need it at all, but probably you're going to need it up to 1 or 2 times a day. If you're needing it much more than that, 4, 5, 6 times a day, then that sort of defeats the purpose of the long-acting, and so the long-acting should be increased. The goal of long-acting pain medicine, one of the big ones, is to help people sleep through the night and not be woken up by pain in the middle of the night. I put this in just as a reminder to me to say these are the long-acting pain medications, fentanyl patches, long-acting 12-hour morphine or oxycodone, or methadone. All of them except methadone are very expensive. Certainly look at the bottom for 100 microgram patch is something I use in a lot of people. 90 milligrams twice a day. This was prices from a couple of years ago at our hospital pharmacy. And so if someone is prescribing for you a long-acting pain medicine, something to think about is whether your insurance, whether you have insurance, and whether insurance will cover it, because it will be a very large bill otherwise. Along with what I said earlier about methadone being a good pain medicine, notice it's also by far the cheapest of the long-acting pain medicines. But again, if you're going to request methadone from a clinician, you need someone who's comfortable using it and has used it before, because it is a little more tricky than the others. Side effects or adverse effects, common ones, constipation, which as I said we'll talk about shortly, but common side effects from opioids, dry mouth, nausea, vomiting in some people, usually when it's first starting or increasing a dose. Sedation, people certainly get sedated or sleepy. And one that's not often talked about is sweats. Some people can, from certain narcotics, can get drenching sweats, or some little sweats. Uncommon, but they happen, are bad dreams or hallucinations. Dysphoria means just not feeling well, but the other end of that spectrum would be delirium or total confusion. Myoclonus are like muscle twitching, and seizures at the other end of the continuum are basically your whole body can be. Pruritus is itching. Sorry for using a couple words of jargon here. Pruritus means itching, or urticaria can be a big itchy rash with lots of red marks on it. This is if you're allergic. Respiratory depression is not common. Doctors are very worried about respiratory depression from these, but it's not common if you use the medications appropriately. And urinary retention. It can make you make it so it's impossible to urinate. And again, that if it really stops, that's a medical emergency. So if you start having difficulties urinating because of a narcotic pain medicine, you need to let your doctor or clinician know. Allergies, and this is important. Many people tell their doctors that they're allergic to morphine or to Dilaudid or to oxycodone because of these top ones. Nausea, vomiting, constipation, sleepiness, confusion, all of these are not allergies. They're in fact side effects. And the reason the difference is important is if it's allergies, the hospital marks it down, you're allergic to these, and so some doctors won't give you other pain medicines because they'll be worried that you'll have an allergic reaction. These nausea, vomiting, constipation are side effects that are expected in some people. So the only real allergies are anaphylactic reactions, and that's when you try something and you can't breathe or have difficulty breathing, or a very itchy rash. These are the really only true allergies for narcotic pain medicines. A bit about tolerance, dependence, and addiction, because lots of my patients worry about addiction. So tolerance is just reduced effectiveness of a given dose over time. So if you're on a specific dose of pain medicine usually over months or years, you will find that it is necessary to increase the dose somewhat in order to keep controlling the pain well. And that's not, sometimes the pain's getting worse, but it's also possible that the pain is staying the same, but your body's getting tolerant or used to the drug, and so you need to increase the dose. And this is the important one. Physical dependence. Physical dependence has to do with, the sign of it is that if you're taking a medication regularly and then you just stop it, you go into an abstinence syndrome, which is your body reacting to the absence of the medication, or can be called cold turkey. And people think this has to do with addiction. And yes, addicts, if they stop, they will have this reaction if they're using the drug regularly. But as physical dependence, it has really nothing to do with addiction, in that it doesn't mean addiction. Anyone who uses narcotics regularly for pain, or any reason, but for pain, for more than a week, if they stop it quickly, will probably, unless they're at the very smallest dose, will probably have some withdrawal symptoms. Back pain, runny nose, diarrhea, there are a whole set of them. But the thing is, you get an absence syndrome with other medications. Steroids, for example, or beta blockers, which slow down the heart. They're a type of heart medicine. Or people on synthroids, thyroid medicines. All of these and others, you can have, your body reacts if you've taken it regularly and then you stop it. And no one talks about addiction to these. So physical dependence and withdrawal does not mean that you're addicted. Addiction is a psychological dependence. And so think about it as compulsive use in spite of harm. So, someone who has troubles with their car and they lose their driver's license, but they can't stop. Someone who's, having trouble fighting at home with family members, but they can't stop. Lose their job, can't stop. That's a psychological dependence. It's a loss of control over the drugs, a loss of interest in doing things that bring pleasure, and it's an uncommon outcome of pain management if the doctor is controlling pain carefully, especially if there's no history of substance abuse. Can it happen? Sure, to a couple % of people. But in most people, that's not going to happen. And certainly in pain patients, most of my patients would happily throw the drugs out the window if their pain went away. They take it because they have to. And I guess one quick word also is that people who need to take their medications, because if they don't, they're going to have pain. So yes, they need to take them. That also is not addiction. And addiction is a word that has means a lot of emotional things to people, and so it's important to explain when people aren't addicted. Other pain medicines, there are other non-opioid medications, acetaminophen or Tylenol, the non-steroidals, steroids, antispasmodics that help with muscle spasms, baclofen, Valium does it too, tricyclic antidepressants, anticonvulsants, and anesthetics. I'll talk about a couple of these. Tylenol, we don't really know how it works, and Tylenol is not a non-steroidal, so if you have inflammation, Tylenol usually doesn't help a lot. But they inhibit cyclooxygenase, which is shortened to COX. That was the thing about COX-2 inhibitors a few years ago, Celebrex, etc. They all have an analgesic ceiling. They're very effective for bone pain and for pain from inflammation. In fact, for some types of bone pain and inflammation, they are more effective than the narcotics. So it's often good to try those first. However, they do have the highest incidence of adverse effects, so stomach irritation, kidney problems, bleeding problems. So they need to be used carefully, especially in elderly. Many doctors won't give these types of drugs to elderly people for worry about kidney damage. And I have seen some patients who have ended up on dialysis because of long-term heavy use of these types of drugs. Again, small doses, probably fine, but too much can be a problem. Corticosteroids or steroids, prednisone, dexamethasone, they can be very, very useful on people who are sick. They can help with some types of pain, like bone pain, sometimes in the abdomen as well. They also can stimulate appetite for someone who's sick and not eating a great deal. They can make people feel better, a feeling of well-being. So these can be really helpful for several different reasons. However, they need to be used carefully. Some people do get psychotic or crazy from steroids. Long-term, they can cause muscle weakness. They can cause high blood sugars, so people who are diabetic need to be careful. They can cause swelling, especially in the legs and the face, and there are other side effects also. So great drugs, but you need to balance the benefits and the burdens of them. Now, I was talking before about neuropathic pain. For burning, tingling, constant pain, the tricyclic antidepressants, which are older medications, can be very useful for this type of pain. And I'm not talking about treating depression. I'm talking physically of treating the pain. Amitriptyline probably has the most side effects, but is the most effective, and so I usually don't use it in people who are quite sick or elderly. Nortriptyline is another, and desipramine has fewer side effects, and that may be one that I would start. Use it once a day at nighttime, usually quite effective. They also can use some of the anticonvulsants, gabapentin or Neurontin, pregabalin, also called Lyrica. These, especially Neurontin, have minimal adverse effects. Mostly drowsiness and tolerance to that develops within days. The SSRIs, the newer antidepressants like Prozac, Zoloft, these generally are not very useful for pain. Great for depression, but not very useful for pain. For the shooting, stabbing, lancinating pain, there are older anticonvulsants, anti-seizure drugs, valproic acid, phenytoin, which is also called Dilantin, carbamazepine, Tegretol. You need to monitor blood levels. People need to get their blood checked probably every 6 weeks. And so the newer drugs for this type of pain has no need to monitor blood levels, and so are probably better to start with either gabapentin, Neurontin, or Lyrica, pregabalin. Both of those can be very helpful for the lancinating pain. Cymbalta, not as helpful for lancinating, but it can be useful for the constant pain. It's important to continue to watch the pain, increase doses until the pain's relieved or side effects are unacceptable. And I often get asked about driving. Driving is generally safe if the pain is controlled. I say a stable dose for at least 2 weeks, that you haven't increased the dose, and that there aren't any adverse effects. You're not sleepy during the day, etc. If there's a question, you need to talk to family members or friends. I even tell people to go out to a big parking lot and have the patient start driving around with a family member or friend in the passenger seat. And the family member or friend's job is to say stop or turn and see how quickly the patient is able to react. You usually need your doctor's okay for it, but it is something to consider that on lower doses, people can drive, but they should get counsel on it. And now the last few slides are on constipation, which unfortunately follows in most people when they use narcotics, especially people who are over 21 or 25. All narcotics cause it. There's some saying that fentanyl may cause less. I'm not so sure about that. But opioids, they affect the CNS as the central nervous system. They affect the spinal cord. They affect the intestines. And when they affect the intestines, they slow things down and make them not work in unison to push stuff along. So things spend much more time in the intestines, especially the large intestine, and that makes the more water is taken out of the stool, and so people, they get constipated. Tolerance to constipation does not develop. Tolerance to sleepiness, tolerance to nausea often develop in most patients, but not usually to constipation. And so it's much easier to prevent than to treat once someone is constipated. Diet is usually insufficient, although I do have a couple of elderly patients who swear by stewed prunes, and I have actually ordered stewed prunes stat within the hospital for a couple of my patients. Over-the-counter bulk forming agents like Metamucil or Citracel, those can be very helpful, but if you're prone to nausea and vomiting, diarrhea, someone who gets dehydrated, Metamucil, Citracel, that form can make things worse. But they're very useful drugs for people who have some basic constipation. Stool softeners can be helpful, Colace or enemas, but especially Colace. Unless you're very young, it's usually not enough if you're also taking narcotics. You usually need one of two types or both. One is a stimulant laxative, Senna, bisacodyl, casanthanol. Bisacodyl here is known as Ducalax, Senecot. Casanthanol is part of pericolace. Often these get combined with stool softeners, at least here in the States, so that you have Senna plus a softener is Docusate, is Senecot S, and the other pericolace. These are very helpful in pushing things along through the intestines. The problem is if you're not eating very much, then there's not a whole lot to push along, and so these drugs can cause some abdominal discomfort without really producing much in the way of bowel movements. So for people who aren't eating much, osmotic laxatives are very helpful. Lactulose is can be very helpful, but it's very, very sweet and makes many people sick to their stomach. So if it works, great. But if it's too sweet, and sorbitol is also sweet, Miralax or the generic Glycolax, polyethylene glycol, this is just a big dose of fiber with no vitamins. It goes in the mouth, goes around and around, and comes out the other end. So for someone who's not eating a whole lot or basically eating bread and things without fiber, Miralax, this type of drug, can be very helpful, or Metamucil, Citracel, like that. Reglan helps push stuff along, metoclopramide. Prokinetic just means it actually causes the stomach to push things along. That can be helpful. And for someone who's really having trouble with opioid-induced constipation, needs to be due to the opioids, Relistor is sort of an antidote to opioid that works for a few hours in maybe 2/3 of people, but it can help in certain circumstances with bad constipation. Mineral oil, magnesium hydroxide, magnesium citrate suppositories are other ways to Thank you.
Thank you. We actually have not too much time, but we have time, Dr. Putnam, if you don't mind, for a couple questions. And we've got quite a lot, so I apologize in advance. We're not going to be able to cover everything. I have not at all. It's a big topic, and I think you have done a wonderful job of helping people assess what kind of questions they need to ask their doctors or have prepare ahead of time, which we really appreciate. We do have one of the more standard consequences of NF, especially NF1, are migraines as well as stomach aches. And we have a question from someone asking if you have any specific ideas for remedies or research related to this pain in NF1.
Migraine headaches are an especially challenging type of pain, that there are neurologists who specialize in headaches. Most of what they see are migraines. I don't really have any specific things to suggest. I'm sorry. I tend to use Imitrex or Midrin in my patients, and if those don't work, I will then usually look for help from a neurologist, because migraines can be so debilitating that I look for someone who has more expertise than I. The stomach discomfort, it really, I'm not, it depends on the source of it. And Barbara, can you tell me a bit more about the stomach pains you're talking about?
I can't. It's not my question, but if the person who asked this question wants to type something quickly, I'd be happy to add any more information on that. On possibly a related note, though, is we also had a question. So much of NF pain is from scarring and having neuromas removed, and someone asked about topical pain relief, creams and such, and the efficacy.
There are topical non-steroidals out there. I'm blanking on the name right now, that can be useful. So like an ibuprofen type medication that can be used, and those creams can be helpful. There are some pharmacies that are called compounding pharmacies, and these compounding pharmacists, they will take different medications and compound them, put them into a cream, things that usually are not topical, can't be put on the skin, but are able to when these pharmacists work their magic. And so talking to your doctor about that, because certainly Neurontin, Haldol, various medications can be compounded and useful. One other thing, that if the pain is fairly close to the surface, remember earlier I talked about deep versus superficial, for close to the surface, if not open, if you don't have open sores, a lidocaine patch put right over the pain can be very helpful. It's usually 12 hours on, 12 hours off, although some doctors will say you can leave them on for 24 hours and then just put on a new one, as long as your skin doesn't get irritated. But those can be very helpful once it's not an open sore.
While you were talking, and thank you, Dr. Putnam, we got a message from your friend and mine, Diana Baldwin, who said that there are transdermal creams, and she has found they are not very effective in her experience. That is a comment I'm relaying from Diana.
Thank you, Diana.
There was a question. So many of our people with NF are not in large hospitals. They're in small places. At what point is it appropriate to ask for a palliative care specialist? And what if there is no palliative care specialist or pain specialist on staff? Do you have any suggestions?
Very good question. Palliative care is a relatively new specialty. It became an official specialty in 2007. So while large teaching hospitals these days usually have palliative care specialists, many smaller hospitals do not. But it's still something to ask about because it's often not advertised. So either a pain management specialist or a palliative care specialist, if you can find them. When to ask? Whenever you feel as a patient that your pain is not being well managed and you get the sense that the doctor isn't really comfortable treating. And then it's very reasonable for you to ask, is there someone else who can help you with this? Is there palliative care? Is there pain specialties? If not, you might ask about a neurologist. They can be helpful with pain. Try and contact, if you're in an area that has a larger hospital not so far away, hour, 2 hours, someplace that you could get to, then checking there to see if there is the palliative care or pain specialist that your doctor could refer you to. Because pain, as those of you who suffer from it know, is something that a lot of doctors just aren't comfortable with.
Well, it is sad that I have to report that we really pretty much have run out of time. I'm sure you all agree that we want to thank Dr. Putnam for sharing this important information. We also want to thank you all for joining us. By tomorrow, February 28th, 2013, this session will be available for viewing in its entirety, even though we wish we had another couple hours. You can view the slides and audio two ways. Again, you can go to our website at www.nfmidatlantic.org or at our YouTube channel, Great Gabby Dog. Before we close, I want to remind everybody that NF Mid-Atlantic survives solely on your donation. If you appreciated this webinar, and I can't imagine anyone who didn't, and you want them to remain free, please, if you could consider a donation, you can do so on our website at www.nfmidatlantic.org. Our next webinar, and I hope you will sign up, is Early Signs of Learning and Attention Vulnerability in NF1. And that will be held on April 3rd, 2013 at the same time, 11 a.m. Eastern Standard Time, Eastern U.S. Standard Time. You can sign up at our website, nfmidatlantic.org. I want to thank everybody, particularly Dr. Putnam, and wish you all a very good day. Thank you. Goodbye.
Thank you all for listening.